Hello to all of you, and thank you for taking the time to listen to me. My name is Amit David. I am both a musculoskeletal and women health physiotherapist. I am a full-time practitioner in an outpatient clinic, mainly treating pregnancy-related pelvic girdle pain patients or PGP patients. I also teach a course for physiotherapists on pregnancy-related pelvic girdle pain, and I have presented the topic in a few professional conferences. Today, I am going to talk to you about pregnancy-related pelvic girdle pain from a clinical point of view, backed by the existing evidence. The first step will be to deal with the prevalence and definition of the phenomena. But even that is not easy because of the lack of evidence and consistency in the literature. If we talk about prevalence, it ranges between 30 to 70%, with increased numbers toward the end of the pregnancy. Regarding definition, pregnancy-related pelvic girdle pain starts during pregnancies and not before the first one. Regarding the location, I do separate pelvic girdle pain from lumbar pain. So posteriorly, symptoms are around the PSIS and down from it toward the buttock. On the anterior aspect, the location of symptoms is around the symphysis pubis, the groin area, the lower abdomen, and along the hip adductor muscles. When we perform a thorough physical examination, we are able to rule out lumbar spine and hip pathologies, as well as to pick up relevant red flags. Clues of red flags in the conversation with the patient and in her assessment may indicate pathologies like osteoporosis during pregnancy or lactation period. This is a rare condition that usually affects the spine, resulting in a number of vertebral fractures along the lower thorax and the upper lumbar. A similar but not identical pathology is transient osteoporosis of the hip that affects the femoral head and may result in pathological hip fracture. It is crucial to identify those two pathologies if we are planning to increase load by exercise or treatment techniques. Increased load on the already fragile bone may result with increased number of fractures. Other pathologies that may require differential diagnosis are rheumatoid diseases with sacroiliac joint involvement, cauda equina syndrome, and lumbar nerve radiculopathy. After ruling out all different severe pathologies, we can start to evaluate and treat the pelvic girdle pain. Pelvic girdle pain can involve between 1 to 3 joints. Of course, the more joints involved, the bigger challenge it is to treat. I usually start treating the one that makes the patient miserable or the most painful one. Physical examination may include functional quick test of the lower body, looking at walking, stair climbing, one leg standing, and one leg jumping. Other relevant tests may include active SLR and various stress tests of the symphysis pubis and the sacroiliac joint. My approach to treatment of pelvic girdle pain patient is based on the biopsychosocial model. From the bio point of view, I use a combination of MWM, mobilization with movement, and CWM, contraction with movement, to modify patient pain and restore mobility and function. Since medication is not an option during pregnancy, I use taping techniques applied around the sacroiliac joint and the pubic symphysis to control pain. The main advantage of this approach is that each modification found during the assessment is easily turned into home self-treatment exercise, enhancing patient autonomy and self-efficacy. Treating pregnancy-related pelvic girdle pain should be done during pregnancy. Although most of the patients improve 6 weeks after delivery, some of them don't. To reduce the chance of chronic pain, early intervention should be considered. I hope it sounds interesting to you, and you are more than welcome to contact me by email with any thoughts and questions. Thank you all.